Well, Dan, thank you so much for the opportunity to be here, everyone, and to tell you a little bit about our work in Haiti. I was privileged to work at Hospital Albert Schweitzer in Deschapelles, Haiti, and that was really an amazing experience. One, because I'd had many years working with my family in the mountains southwest of that hospital, about 5 miles out, and so that was the experience that really formed the ability to create this program. The program addressed two problems, and at the beginning, some people might think these two problems are related but rather separate, but what we found out was these two issues are really integral to each other, and those are measuring surgical quality being one. We set out to measure the quality of surgical care being delivered at Hospital Albert Schweitzer, both in the inpatient setting and then in the outpatient setting. And in the outpatient setting, that was really our true challenge. And the reason is this: in global health right now, it's always been true, but right now it's sort of been getting more popular to recognize that surgery is an incredible need around the world. And if we're going to advocate for more surgery being done, the whole field of surgery in global health is dying for a reliable measure of outcome. Now, a lot of people think that true outpatient, at-home, 30-day or longer outcome is just too difficult to get at in these settings because people live, over hills and down ravines and across muddy roads that vehicles can't get to, and they don't come back for follow-up for many, many reasons. And so a lot of people have stepped back from outcomes and said, well, all we can measure is process measures, or all we can measure is in the hospital. And we wanted to challenge that and see if we could do better, building on successes that came out of here at PIH with community health workers and tuberculosis and HIV. My thought was, if a community health worker can watch someone at their house take ARVs, they can surely go to the house and see how a surgical site is doing from an infection standpoint. We chose surgical site infection because it's sort of disease agnostic, procedure agnostic, specialty agnostic. Every person who cuts someone's skin creates a risk for infection. So an infection would be an outcome that applies across the board for surgery, and later we could focus down on individual outcomes that pertain to particular specialties or particular problems. So we went after surgical site infection. That was one of our problems that we wanted to address, was measuring surgical outcome at home at 30 days. And I'll get into how we did that. I had a connection in this particular community in the rural mountains, and I knew I needed community involvement to get traction for this program. And I discovered that was a second but very related problem, in that this population was not getting into the hospital for surgical care. This has been a long recognized problem at this hospital and also around the world, is that in poor countries, just like in rich countries, there's a lot of disparity. There's poorer areas, there are richer areas. And universally, the poorest areas get the poorest utilization of healthcare services. And our population was no different. They had 2.5 less times surgery operations being performed than their valley neighbors, and that's controlling for the size of the population. And so we wanted to use the health workers to gain access as well. So we use them to navigate the patients through the process at the hospital to get access to care. And I'll address that too, because it's a complex problem, because there was free care available at the hospital, and it seems a little counterintuitive to say we have a functioning free care program, and yet an entire segment of the population isn't getting the same amount of surgical access as others. And why is that? The hospital administrator said, this is crazy. How come I have a free care program? How come these patients aren't coming? And you hear the typical things, like, it must be something out of our control. And I didn't know the answer to the question. So what we did was we brought 4 people from the mountains that needed surgery through, and then I saw in stark reality what the problem was. These patients are illiterate. Only 34% of my patients in the mountains can sign their name on a piece of paper. That doesn't mean they're literate, that just means they can write their name. To ask you to go through a hospital, go to the clinic, get your radiology exam, get your laboratory tests, get your chart, negotiate all the processes, is like asking them to go to NASA, jump on a Saturn V, and walk on the moon. It's just ludicrous. So what we did was we trained the health workers in one aspect to navigate patients through the system. They learned where the charts were, and they would do it for them. They would get the chart, and they would literally take them by the hand to the social service program, which is funded by the Bunder Partnership in Switzerland, to get access to free care. And then we measured that. And how do we measure it? We measured it with at least 2 control groups. We had a control group in the mountain area that did not receive our intervention. We had a control group in the valley area, which receives a high service rate, that also did not receive navigation. And then we had this targeted mountain group that we did navigation for. And we went out into the communities, advertised widely. And this is where some of the craft comes in, because I had a good friend of mine that I've known for 17 years who's a pastor and a community leader in this mountain community. And he was the one that organized all of the things at the community level. So we actually paid a man with a megaphone to go house to house, village to village for a week to tell everyone to show up at this particular church at this particular time if they thought they needed surgery. We had about 130 people show up, and 65% of them really needed surgery. But then we prioritized them according to how sick they were. Then we divided the community up based on geography, and then we separated them out by health worker. And then we called them down about 5, 6, 7, 8, 9, 10 at a time every week to get them through the process. And we served 40 people in 4 months. And we had 86 who needed surgery and about 50 who had high priority. And all 50 of them got an opportunity to come, and about 4 or 5 didn't come for various reasons. But the rest got surgery. And when we controlled for it with the control groups, we saw that was an increase of 4 times relative to the baseline before we started doing it. We also tracked it by month, and what was interesting here is that when we stopped, the rate went right back down to baseline. And that tells me that it's not education alone. They actually need to have agency. They actually need to have someone to accompany them through the process, to hold their hand and say this, because they have no confidence that they can negotiate this complicated process on their own. And that tells me the necessity of using the health workers for access. So the next component of our program was to measure the cervical site infections, and what we did was we partnered with SANA, which is a mobile solutions group from MIT here in Boston. They have a lot of experience writing mHealth software for global health applications around the world. I've worked mostly in Africa and India. And we worked together to design this very simple survey about symptoms of infection. Every question is yes, no. They're all pretty obvious to people who take care of surgery patients. It's about fever and pain and redness and drainage and a spontaneous opening of the incision. But the first question is unique because it says, are you at the patient's house? We allowed them to do the visits anywhere they found the patient, but we wanted to know if it was at the patient's home location. And if, actually, regardless of whether they say yes or no, the application pulls GPS coordinates in the background. And this is important, and we also asked for a photograph in the 9th prompt here in the survey. And we had to do a lot of teaching about how to take a good photograph. That was probably our biggest learning challenge. And people that haven't used smartphones or haven't used cameras before, not taking it with the sunlight in the back and the right colors and the right time of day was what we worked on most. And this was really interesting to people who had run mobile health programs in Haiti before, because they said, hey, we've asked for free text data, and we've had a lot of difficulty with people falsifying data because there's no quality assurance mechanism. And this is sort of by accident, but sort of fortuitous in that you cannot fake a report if I know where you did it and you have a photograph of the surgical site. You can't fake a hernia incision, and I know where you did the visit. So my health workers we chose good people with high intrinsic motivation, which we've talked about, but we also had quality assurance mechanisms in place to where they actually had to walk out the 10 miles or the 8 miles or whatever it is to the house because I would know where they went. And the 10th question I'm really proud of because it asks the health worker, what do you think? We weren't primarily trying to train them to be surgical providers, as to be able to assess infections, but we wanted them to make an assessment because we wanted their skills to grow over time. We didn't want it to just be, oh, I did my survey, checkbox, I'm done, I'm going home. We wanted them to feel responsible for the care of the patient and grow in their skills, and boy, did they did that. They at first they were like, I'm very unsure if there's an infection, and now they're like, there's no problems. I know there's no infection, or I do have a question, I do have a question. So in summary, we had 39 subjects. They did 117 home visits, and we have a map here showing the GPS locations of the visits. The next slide shows representative photographs of what we get. What kind of quality did we get out of the health workers? We rated all the photographs on a quality rubric about whether it was blurry, whether you could tell what the incision looked like, and then this is what we get. And it was clear that 96% of our photographs came in at this representative quality. So you can see very clearly here, this is a forehead lipoma and a left inguinal hernia incision. And I can have a lot of confidence as a surgical provider that I can see that well enough to say, yeah, I'm pretty confident that that incision is fine. Or that incision is a little bit iffy, like post-op day 30 here, the third photograph on the inguinal hernia incision, you can see a little drainage, and we sent that patient back on 30 days and actually did diagnose a little bit of a draining seroma, and then we followed him out to 50 days to make sure it was okay. And so our total results are on the next slide. We had 95% of the patients complete 30-day follow-up. 92% of the visits were on time. Like I said, 95% of the photographs were adequate. And then we measured agreement with the surgeon's assessment within 24 hours of each other. So the health workers would see the patient, 24 hours later they'd attend their clinic appointment, and then we would say, what do you think as a surgeon? Is there an infection, is there not? And about 84% of the time there was agreement between the two. And now we're setting up to expand this program. We've enrolled 350 new patients, and we're going to go forward and use that bigger sample size to further characterize when the agreement is more robust, like when there's no symptoms, maybe those patients don't have to come back for follow-up. When there is a little bit of symptoms, then we need to get them in soon. I wouldn't advocate that the only follow-up be a health worker at home for a patient, but maybe if the post-op visit is mostly about a wound check and you're not really concerned about much else, and there's no symptoms, and you see the photograph as a surgeon, maybe then we can say, hey, maybe we can unburden the system for this, we can free up clinic time to see new patients. But we'll need the bigger sample size to really hone in on that. And the last slide here is just the results for our patient, Sover, who got the thyroidectomy, and she looks a lot better now. And I think I'll stop there and if you want to have some questions, and then maybe the audience can have some too.
Sure. It's wonderful, and I hope you guys are as excited by hearing these results as I am. There's a lot in here that's just absolutely fascinating. If you had to then make this program, let's say, national, right, and where you have that same dynamic, where you have the mountain valley dynamic, do you think that same careful craft would persist? And if so, what do you think are the core elements that would implement that?
We had a lot of supervision. We had explicit pay per performance contracts, and we chose individuals with high intrinsic motivation. I think if you're scaling to slums and urban areas, you'd have to do the same. You'd have to really pick people who know the community. You'd have to choose people with high intrinsic motivation. You'd have to give them extrinsic motivators to help them do their job, and then you have to supervise them. You can't just say, oh, it's going to be good. We chose a pastor or something like that. It's like, you can't do that.
But we'll be back in touch soon about what the next session will be. And thanks so much, everybody, for calling in.
Thank you so much for the opportunity, Dan. I just want to mention one more thing, that if you look on my YouTube channel, there is a video that describes this program. If you want to disseminate it, take a look at it. And it's a really good example of what these problems are and gets into some of the nitty-gritty on the solution. So just search my name on YouTube and you'll find it. Thank you so much for the opportunity, and look forward to continuing the conversation later.